Hello everyone, I am Mauricio Hansen. I am a fellow at the clinic and came from Argentina. I'm going to talk about our experience in double-level decompression by UBE and its feasibility. So multi-level surgery for lumbar stenosis is commonly done by laminotomy or even laminectomy. And the use of biportal endoscopy raised concerns by the effectiveness, the rate of complications, and moreover, the duration time of the surgery. And it raised the question, it is feasible, we can done it, so this is our experience. To put it in context, there's not much in the literature written about this. This is a meta-analysis about 10 papers, 5 who talks about biportal endoscopy, but it was published this year in 2025. And well, the mean operative time was 104 minutes, and the dural T rate was 7%. So what we want to do was to assess the feasibility of the UBE by double-level decompression. It's a retrospective single-center observational study. We include all the patients who underwent double-level UBE decompression since the beginning of the implementation in this clinic from April 2022 to December 2024. We did the data extraction and demographics, surgical data, the pre-op and the post-op clinical evaluation of the ODI and the pain score. So just to illustrate how we do it, this is a patient that we operated with Guillaume a month ago, but we are really progressing and incrementing the effectiveness. And this is a free-level decompression that we did in less than 3 hours, so it's a really good decompression. He had a little hematoma, but no reoperation. So the results of our experience so we can see the image here. The first year, not so much, but in the last year, we did more than 70%. And well, the mean operative time was 55 minutes for level. That it really is similar to the literature. We have 5 dural tiers on 70 operated levels. It concords with Philippe has spoken on the meta-analysis also, and we have only 1 post-op complication and altered vision on the right eye that is recovering. So the clinical data, we show that the patients did well. We didn't have much more complication that could raise a concern about the feasibility of the technique. So I think it's a good technique to do, it's feasible, and I think it's, as a matter of technicity, as surgical teams gain expertise, the implementation is going to become more widespread. And I know that some surgeons do 1 level and after 1 level, but I think this technique can be very utilized and as a well. So thank you.
Thank you, Dr. Hansen. Does anyone have a question? Yeah.
More than a question, beautiful presentation, of course. More than a question, just a comment. When I start doing this, I mean, UBE, I was, of course, absolutely I am enthusiastic about it, but, you know, I went for multi-level decompression, not only 2 levels, 3 levels, 4 levels, you know, and it was because, of course, I mean, I was so excited to do this that for me, each level was a different surgery, of course, right? But then, you know, when I got older and tired about, you know, everything in general, I believe that even when you have multi-level stenosis, right, you have 3 levels, 4 levels of stenosis, this is my impression, okay, maybe you can disagree and it would be nice to share ideas, but I believe that with 2 levels, in those cases, your patient is still going to get better. What I'm trying to say is that maybe the debate is not if it is useful to do 2 levels, because it is useful and absolutely applicable. The thing is, what do we do when we have more than 2 levels of stenosis? Because it's pretty common, right? In older patients, you have 3 levels of stenosis, 4 levels of stenosis, or the whole lumbar spine stenotic. How do you choose where is the main pathology? What do you operate? You operate the what? Of course. Yes, but sometimes it's difficult. Sometimes, no, I agree, of course. That's why right now my practice
Clearly
is,
up to 1 to 2 levels, no more. Usually.
that's right.
Usually.
That's right. That's what I'm
The
trying
main
to say.
culprit, sometimes it's only 1 level.
Yes, absolutely. That's what I'm trying to say is that sometimes you get excited, you want to operate all the levels, right? It's really tiresome. It gives you neck pain, right? 4 hours, 5 hours of decompression. And maybe with 2 levels of decompression is more just than enough, right? And very good results.
I don't agree.
Me too. Me too. I not agree because why don't do more levels? Because you are tired? Because you have time? So it's skill of us? No, the patient have. We have to classify when we have to operate in moderate, in severe, in critical. But if our patient have 4-level critical stenosis, they need 4-level decompression. And we can talk if we do it in 1 stage or 2-stage surgery, but the patient needs this decompression.
Yes.
So we need to be fast. Claudication. Neurologic claudication. So the problem is we try to explain that we only decompress 2 times because it's too long the surgery. This is not the problem.
No, that's not what I said, Ariel. I don't say it's because of time. I said because of the benefit that patient has. How can you compare if you operate the 4 levels or 2 levels? You should have to do a study, right? I mean, in order to
we not have a result, but we have MRI, postoperative MRI, and the radiologist says that there still be an stenosis in the upper level. So the patient is going to need a surgery because the radiologist said that you have an stenosis. So
Shouldn't be doing endoscopy.
maybe we have to,
Yes.
but
Do you ever do pre-op PMG and studies?
yeah, absolutely.
You do.
Even CT.
But in that sense also, if you ask for an MG, there is always 2 or 3 levels, 2 or 3 routes that are responsible for the whole problem. I mean, and you sure have this kind of patients. You have maybe L2, L3 stenosis, L3, L4 stenosis, L4, L5 stenosis. You ask for an MAG, and the radiculopathy is only L5.
But that's
L2, L3 is good, L2, L3, L4 is good.
EMG is not good.
You need to do it. But just for the sake of the stenosis, maybe it's not worth. That's what I'm trying to say.
Yeah.
Normally, we have just battles with uniportalists,
What?
not with UBE surgeons.
No. It's a discussion
But
that we have always
no,
because
but I agree with you. But normally, you had the chance to meet Dr. Skizas, and I had this chance too. And
He's a great guy.
yeah, he's a great guy. And for him, he thinks that we have always a symptomatic level. And we have to analyze to see your patient, to analyze the images, but it's our job. But he thinks there is always a symptomatic level. Not it's difficult to be 2 levels, but it's difficult to be 2 levels because at the end you have always 1 level less decompressed than the other because you want to go faster with 1 level or the second level. Your team is tired, not you, but your team, your anesthesiologist is tired, and blah 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 blah. But at the beginning, I never do 2 levels. If I have 2 levels to do, it's 3 months after. But if I choose well my symptomatic level, when I see my patients 2 months after, it's better. I don't do the other level, and I begin to survey him. But we discuss with several surgeons, and we never do 2 levels. And we have an algorithm, and if you want, we can discuss in Sevilla, Macarena.
In the end, you don't operate the 4 or 5 or whatever levels of the stenosis. That's what you're saying, right?
Yeah. Just one.
Yeah, but maybe we should do
But just one, but we have to, because L5S1, left L5S1 herniated disc, it's our life, and it's simple. but it's our life. It's simple. You have a S1
It's rare to have an
sciatica,
stenosis.
blah blah. Okay, but we have to have a reflection for these difficult cases. I don't know if it's difficult, but we have to analyze and to have some algorithm to decide which level is symptomatic. MRI, CT scan, you have an anatedis, calcified ligament of rubber. We have an algorithm we can discuss together because I think it's not the
So what are your data? I mean, what is the percentage you have really reprogrammated for a second surgery? The one you said I have 2 levels, 3 levels, I will do once. How many you have reoperated?
We did last year more than 150 stenosis, and on these cases we had 17 double levels. Okay, and we explained to the patient, okay, our strategy is to operate you 2 times, but just one cost, even if I have in liberal practice, and I have to choose the good level, the symptomatic level. I have to see you 2 months after, and if you have any symptoms, we will do the second level. Okay, on these 17 patients, I operate 2 times, just 2 patients, because the others are better. Okay, I will survey you. I don't do the second surgery. Okay.
Yeah, but you have to follow this patient because if this patient is going to have symptoms, the problem is the two-stage surgery. I think is good. I think two-stage surgery is good, and you can propose for the patient. But many patients, for example, in Spain, says, "So I have to 2 surgeries."
It depends on the information.
Yeah, absolutely. I think this is very important. So you can explain that is maybe, yeah, depend of the social media.
I think it depends on the reality of your country too.
Really?
At least in Portugal, that is impossible. In Portugal, if in private practice, it's not possible for 2 reasons. The first reason is the patient. If a patient is operated twice in Portugal, it's a failure. For him, in terms of mentality, it's a failure. And you can't, and the patient, if it's operated twice, it's economic burden that is twice for him. You can propose a surgery and he only has to pay one. So we have the same problem. Sometimes we have multi-level decompressions. We follow like the famous quote of Michael Phelps, our job is to decompress. So sometimes we decompress the second level. Normally I start always for the symptomatic and what I think is worse, knowing that sometimes the second level I'm just decompressing probably the image, but it's better that then the patient has to have a second decompression because it's hard for us in terms of logistics.
There is no
Logistic, the payment, the patient understands it.
But the majority of the patients are operated just 1 time.
Yes.
There's no logistic.
But the ones that are not, they have to pay a second surgery.
Only to imagine that I have an stenotic level that you not decompress yet.
And if he does an MRI and the radiologist,
Maybe you have arthrosis on your right knee. Okay, but I don't have to put you a prosthesis.
Yeah, it's the cultural problem.
Yeah,
But you can also explain that we have the same problem, but I just explained that if I'm doing 2 level, maybe 1 for nothing, it's twice the risk. And even if the risk is very, very low, the patient listen, oh, I have twice more risk by neurological deficit after surgery, even if twice 0.1%. And maybe for nothing, I explain if the symptom remains, we will do the other level after that.
yeah. Yes, and the results of Christiania are impressive. It's 10% of reoperation. It's very low.
But what they in Korea what is happening? Dr. Song, Dr. Park, they have 4 level decompression. These guys have 10 years in advance. If they have 4 stenosis, they decompress the 4. Even in cervical, is it dorsal or is it lumbar?
Yeah.
About that, you know what we should do? It's maybe set it in another basis, because we are talking about decompressing levels. Maybe we should be speaking about decompressing roots. Exactly, because with one level, you can decompress 4 roots. Okay? It's something different. I've talked with Jesus months ago before you met him.
It's a great debate. I think we have to organize a table at CEVI maybe next year to think about something. Yes, multi-level surgery, what we have to do. It's a very interesting debate. Thank you, guys.